Welcome to Weekly Infusion with Dr. Drew Pinsky and Dr. Bruce Heischober. Weekly Infusion addresses medically related topics. It's in the know, entertaining, and everything you want to know about health and medicine. Now may I present to you the very wonderful Dr. Drew and Dr. Bruce.
14 million males worldwide are living with this disease, but with your help, we have a chance to save them all.
The risk of prostate cancer rises rapidly after the age of 50. I was diagnosed at age 52, but some men can develop prostate cancer as early as age 40.
That is the video we did with Rob and Dax to save the males. Go to savethemales.org. Just go to drdrew.com/savethemales. You'll see the video.
Very artistic. I like that.
I know.
Yes.
And what Rob Riggles and Dax Shepard, I mean, what better way to spend the day than those guys? And Dax and I then did a satellite media tour on the heels of this. It's Prostate Awareness Month, and I have prostate cancer. You and I have discussed many times. And we are going to dedicate this show to that topic.
Best topic it's relevant to me, relevant to you.
It's relevant to all males because 1 in 8 males get this damn thing. I would say that 100% of men at 100 will get it. If you live long enough, you will get it. It's different, treated differently. It's probably different diseases at different age groups. And we are learning now that it is actually genetically different diseases, and it evolves across the lifespan of the tumor even. There's a lot to get into here. And so first, before I do, though, how's your trip?
Great trip. Went to Norway, visited family, and then a couple days in London. So I insisted on jogging and getting soaked in the rain. And
that's why you're coughing.
Little cough, but
Susan, he's sick. Be careful. Watch out. And so I did a couple without you. I missed you, but I did them anyway. And I thought I was jealous. Thought of you in the Scandinavia and London, wherever the hell else you went.
Keep the pirate ship going. I'm glad you did them.
That was the plan. All right. So this is a very special episode. Before I introduce our guest, I want to, hi to Facebook Live too, by the way, all of you out there. And Susan's monitoring it, so you can ask your questions there. You can call in here, whichever it is. Do we have a call-in number, everybody? Is that
right there on your sheet somewhere?
Somebody help me. The call-in number. That should write it down for me.
It's actually going to be on the screen. So.
All right, it'll be on the screen. So everyone watching on Facebook, it's on the screen. In any event, this is those of you that are listening as a podcast. Obviously, this is not live. It's on a podcast. It's live for the Facebook viewers right now. I want you. It's 323-649-8268. 323-649-8268. But we are going to get into the weeds of prostate cancer today, and I want you to listen very carefully. Anyone should be able to follow this conversation. If you jump in the middle, it's going to be tough. You have to start from the beginning with us. We're going to talk about some complex biology, but my guests and you and I kind of know how to talk about it in a way that if you follow our logic, you'll understand. The words may not make perfect sense sometimes. You have to look up some of the vocabulary. If we
I'll act as every man if I could.
Be dumb today, Bruce. It's my privilege to welcome Dr. Matthew Rettig. He is a medical oncologist. He's a physician scientist. He's the medical director of the Prostate Cancer Program at UCLA's David Geffen School of Medicine. That's where I get my prostate cancer care. And it is Prostate Cancer Awareness Month. Dr. Rettig, thank you, and we're really privileged to have you here today.
Thanks for having me.
It is really our privilege. So if anybody, by the way, wants more information, if I forget to say it, go to pcf.org, Prostate Cancer Foundation, or contribute at Many vs. Cancer or at Save the Males. I'm telling you, the research people like Dr. Rettig are doing is, in my humble opinion, you tell me if this is an overstatement, is resulting in breakthroughs that is having repercussions throughout the field of oncology. All cancers are benefiting from some of the breakthroughs in prostate cancer.
Yeah, I think you're touching upon a really important point. What we're learning about in prostate cancer can be translated into many other cancers. So the benefit of the research in prostate cancer will affect men and women with all types of cancers.
Which is crazy because the three of us maybe are old enough to remember this. Prostate was a sleepy little cancer that no one even paid attention to.
Right.
So once in a while it killed men and nothing we could do really about it. The urologists who were in the field weren't all that interested in it, particularly strange as that sounds.
Right.
It wasn't their thing. And now their cancer is leading the way into all the other cancers.
Yeah, I think that's exactly right. It's really started over the last 20 to 25 years, especially with the growth and development of the Prostate Cancer Foundation.
Which is crazy. There's one little, this is Michael Milken's foundation. He was told he had 6 months to live, and he went, that can't be right, and raised money and has developed a group of brilliant people. And now I think fund's the most creative research in cancer out there.
Yeah, I would agree with that,
Yeah.
but I have my own bias.
Well, I do too. I'm on the board of directors with it, but I've learned. I mean, I was sort of asked to be on it. I didn't know quite what I was getting into, and I've sat through many presentations by people like yourself, and talked to these researchers, and they are given the money they need to do what they need to do, which is very unusual research. How does it usually work?
Well, usually there's, first of all, the application process is streamlined and simplified with the Prostate Cancer Foundation. So if you apply for money and your application is accepted, you get the money and you can start your research much more rapidly than in traditional
And they don't
formats.
want any feedback until you're satisfied you're where you want to be, and then they'll ask how to go. Essentially, that's all it is.
Exactly.
Yeah. Which is not how traditional research is done. Trust me, you know.
And another critical point is that you can explore new findings with the research funds that you get from the Prostate Cancer Foundation. With traditional funding mechanisms, you have a list of aims, and you're kind of obligated to follow those aims. You can change them, but it requires quite a bit of effort. So the Prostate Cancer Foundation gives the scientists the freedom to explore.
It's creativity. I mean, science should be a creative endeavor. At least research should be a creative endeavor, and it gives them the ability to do that. So, if people want to be, this is not specifically a fundraising afternoon. We have none of us drive any direct benefits. Do we have anybody? Do you get no?
Nope.
But if you want to be a part of the cure in cancer, particularly prostate cancer, check out pcf.org. Many versus Cancer. Be a part of the solution. $1. Everything's useful. Everything is useful. Yeah. And what's great is, trust me, every dollar gets put to great use. So let's talk about prostate cancer. Where should we bring this conversation? How do you like to start it?
Well, let's just talk about the burden of prostate cancer.
Yeah.
Who it affects, how often it affects, and how lethal it is. So, first of all, in the United States, there are about almost 200,000 new cases of prostate cancer in the United States. Other than non-melanoma...
Per year.
Per year, yep, per year. So, and there are about 3 million men walking around with the disease in the United States.
I'm one.
And about 14 million men walking around with it worldwide. About, as you said, 1 in 8 or perhaps more men in the United States will be diagnosed with prostate cancer sometime during their lifetime. So there are about 27,000 deaths attributable to prostate cancer in the United States, and about over 300,000 deaths in the world. In the United States, it's the second leading cause of cancer-related mortality amongst men.
Mortality.
Mortality.
What's number one? Colon? Lung?
Lung is number one, far and away, but prostate cancer is the number 2 cause of mortality.
There's a piece of data they also throw out there. I was going to interrupt. It's not the data you were quoting, which is that it's the most common. It's the second most common cancer in men. It's like, can't we just take skin cancers and push them aside?
Right.
We're not talking about melanoma. We're talking about we all get skin cancers. That's a given.
Right.
Particularly if we live in sunny areas like this. Okay, it's the most common.
It's
cancer.
the most common.
Yeah,
The skin
common
cancers
stuff,
that we're talking about are the non-lethal forms
Right.
of them that you can
That's
kind of
right.
freeze off. And
Yeah, we all get them.
Right.
Prostate cancer is the number one significant cancer in men.
Agreed.
Yeah. So keep going. So that's the burden for
So
death.
that's the burden. And what we know is that the disease behaves very differently amongst
in different individuals.
in different individuals. There's a lot of what we call inter-individual variability. So some patients can be diagnosed with the disease, and it never poses a threat to their life. Other patients, the opposite is true, and it can rapidly progress and develop what we call metastatic disease.
Okay, so let's start with that piece of the puzzle, which is how are we doing at determining which kind of cancer a guy has, and how are we doing in terms of picking it up in the right time frame and then doing the right thing with it once we pick it up.
Right. So I think we do a pretty good job of detecting it. There's a very small percentage of men in the United States who are diagnosed with advanced disease. So less than 10% of men are diagnosed with metastatic prostate cancer. In other words, at the time of diagnosis...
Distant mets or proximal mets?
Distant mets.
Yeah.
So that means the cancer has spread through the bloodstream and gone to another organ.
So you're not talking about just spread locally in the pelvis. You're talking about elsewhere.
That's right,
Yeah.
right. So in that setting, in the sort of localized setting, that's where we have to do a better job at trying to predict which cancers are a problem, which cancers are potentially lethal, and which cancers may remain quiescently within the patient without posing any clinical problems or threat to the patient's life.
What percentage do you think at diagnosis are going to just be indolent?
The majority.
Majority are indolent.
Yeah, the majority.
So Bruce wants to talk to somebody later in the thing who's now doing that diet and this and that. I'm thinking to myself, he would have been indolent anyway, whether he managed his diet or not.
Even with his Gleason's.
3 + 3 is not that big a deal, is it?
Yeah.
That's correct. So there are different ways that we can predict the aggressiveness of the cancer. A lot of them are traditional, tried and true methods based upon the standard pathology and the size or stage of the cancer and the patient's PSA, which is a blood test. It's a protein that is secreted by the tumor cells into the bloodstream and is detected. And the higher it is, the more likely the patient has prostate cancer. The problem being is that many patients who have high PSAs don't have prostate cancer.
What age is best to get a baseline for that? Because it's the change that's more important than the absolute value, right?
Right. So both the level or absolute value of the PSA can be predictive, but of whether or not the patient has prostate cancer, as can be the rate of change in the PSA. So PSA screening, which is a whole nother subject, is somewhat controversial. There have been some studies which have shown that it is beneficial. In other words, patients who get screened as opposed to those that do not get screened have an improved what we call prostate cancer-specific survival, meaning they're less likely to die from prostate cancer. There is some controversy on this subject, but in general, for a patient who is interested in screening, who doesn't have any particular high-risk factors, then we would recommend an age of about 50. For those who have a strong family history, we might recommend screening at an earlier age, such as 40.
Before that recommendation, I started screening myself at 40. I have pretty good instincts. I just had an instinct it was the right thing to do. 1, 1, 1, 1, 1. I got sick with an H1N1, a different viral illness, and Susan's instinct was I was sicker than I should have been. Wow. I needed to go see a doctor, and I was like, no. And as part of that visit, they did a PSA, which had been about a year since I'd had one, and went from 1 to 4. Still normal.
Right. That's the thing. If you had initially had it and didn't know that 1 was your baseline.
That's right. And it's been 1 for years. The internist asked me to see a urologist, and I was like, come on. Check it again in 6 months, which would have been a reasonable thing to do, by the way. But it's like, come on. Forget it's me. Forget it's a peer. Go see a urologist. Urologist goes, yeah, you're right. Probably just prostatitis. Treats the prostatitis, does not go down. Treats again, does not go down. Well, now you've bought yourself a biopsy, and now I'm pissed. I'm like, are you kidding? This is overkill. Are you kidding me? This is ridiculous. Boom, 3 + 3, Gleason cancer.
And then I remember you were having routine ultrasounds and
no, I was having routine biopsies.
Biopsies. Right.
We'll talk about that, the watchful waiting stuff in a few minutes. So
there was a recommendation, 5-6 years ago, not to do routine PSA screening, and that confused me because just to have a baseline seemed to be important.
And Bruce, urology versus American College of Physicians separated on this too, which I thought was ridiculous.
Yeah. So the U.S. Preventive Task Force came out with a recommendation. It's called a recommendation D, which actually recommended against PSA screening, not just neutral. They were against it.
At all, ever.
Yeah.
No screening, right,
ever.
Irrespective of age. Yeah.
But still digital exam.
The digital exam can be done, so they did not recommend against that, but the PSA screening at that time was considered a no-no. More recently, based upon accumulating data since that initial recommendation, the U.S. Preventive Task Force has changed.
They've reversed course completely.
Right, not completely. They haven't recommended for it, but
only to save face.
Right.
Humbly. Right. they reversed course fast
Big
because
time.
That was bad, and clearly the wrong position to take in the first place.
Right. So we actually saw that more patients, since the recommendation against screening, more patients were presenting with advanced metastatic disease than clinically localized disease, and this was shown over and over and over again, multiple studies.
Yeah. Surprised there wasn't a class action suit against the U.S. Preventive Task Force, but I'm just saying. So in any event, so there's the screening issue. So if you have a first-degree relative, get screened at 40. Everybody else, 50. PSA, digital
African American.
Yep.
Well, they are more likely to get it by 1.6 times, and they're more likely to die of it by
about twofold. Yeah, it's pretty high. Yeah. It's not clear whether there are socioeconomic factors versus biologic or genetic factors, but we do think that there's something intrinsic to the tumors, prostate cancers that African Americans develop as opposed to non-African Americans, that they have a greater, more aggressive biology.
My sense is it's not socioeconomic, because I got plenty of well-to-do African American patients of mine and people I've referred over to PCF. Who, by the way, had, extremely healthy, had no symptoms, no socioeconomic problems, attentive to their health, and regularly screened, presenting with advanced disease.
Yeah.
Boom.
It's also a disease of modern. I was reading something about 40-degree latitude. Above that, higher incidence. Asians less until they come to the States, and then higher incidence. So, and it has to do with DNA and oxidative degradation products. And
so there's what you're referring to is that there are clearly age and geographical variations in the risk of developing prostate cancer. The most the race that is most likely to develop it are African Americans living in the United States. If you look at age-adjusted statistics comparing African Americans or blacks in the United States opposed to African blacks, American blacks have a much higher incidence of developing prostate cancer. And the same holds true for Asians that live in the East as opposed to those that are in the United States. So when Asians move to the United States, it's the second generation that starts to develop prostate cancer in higher incidence. So there are clearly environmental factors. The precise factors, whether they're dietary or other factors, have not been clearly teased out.
Vitamin D, it's not.
No,
vitamin D has only been shown in metastatic disease to have a function, right?
It has been shown in preclinical studies. There have been studies looking at supraphysiologic doses of vitamin D that don't help. And vitamin E and selenium were originally thought to play a role, and then control trials were done whether supplements with selenium or vitamin E, would reduce the risk. It turns out no. In fact, the opposite. Vitamin E actually may increase the risk of developing prostate cancer.
And then smoking, yes, is a problem. Alcohol, not well correlated.
Yeah, there are a lot of factors. It's very hard sometimes to definitively establish a link when the factor is not posing an oversized effect on prostate cancer, because you can't do a controlled trial of smoking versus no smoking. You can't tell patients, okay, we're going to give you a cigarette and we're going to follow you and take patients who don't get cigarettes and follow them and see if they have a difference in incidence of prostate cancer.
So we're going to get into a discussion about genetics, genomics, and epigenetics in just a second, but I thought maybe first take a call just to kind of give us a little breather. Everyone with us so far on Facebook, Susan? Everybody understand what's going on? They all have any questions?
Yes, but take the call.
Okay. Yes, they have questions, or yes, they understand what's going on?
Well, they're making comments, so no questions.
Okay.
Yet.
All right, here's a call. Caller, I'm sorry. Oh, John, you had a question for us.
This is Jason. Can you hear me?
All right, Jason, go right ahead.
Okay, so I have advanced metastatic prostate cancer. I participated in a trial at the NIH where I received ADT, chemotherapy, and then the Fowlpox vaccine. But I was doing pretty good initially, then my cancer continued to advance, so I was asked to leave the trial and seek some other therapies that might help. I've tried some things. Nothing really is working at this point. It's advancing. It's still in my skeletal system, primarily in my bones, hasn't gone to any organs. And I am getting ready to start a round of, radium-223. But I'm wondering about targeted therapies. I think I'm getting sort of down to the end of my options here, and I've been reading a lot about targeted therapies.
How old are you?
And I guess my question would, I am 55, just turned 55.
And you had the condition how long?
So not that long. I was diagnosed maybe just over a year ago, but I had a Gleason index of 9, and and it just kind of, really got aggressive. And of course, I'm castrate resistant at this point. So I guess my question would be the radium-223, does that sound advisable? And I'll probably have some other localized radiation for some spots that I'm particularly experiencing some pain in. And then targeted therapies. I know there's nothing really beyond maybe a trial phase right now, but do you guys know of any good targeted therapies that, might be open for participation in a trial?
So let's get Jason, hang on. You sit and listen for 1 second. I'm going to keep you on the line, so if you need to interrupt, please do.
Sure.
He's talking about radium labeled directly to the cancer cells, right? Which, correct? Am I right on that?
That's correct, yes.
And I've seen that research. And it's, to me, Jason, I don't want to speak out of turn, but to me, it's some of the most exciting research out there. So no, for me, that frames this conversation. Let's talk, though, let's back into it through what he means by castration resistance.
Sure.
Okay.
So we've known for about 75 years that prostate cancers grow and survive in response to male hormones like testosterone. Male hormones collectively are called androgens. So the mainstay of the initial treatment for advanced prostate cancer historically, has been endocrine therapy. That is therapy that reduces the level of serum testosterone.
Shut your testosterone off.
Right.
Shut your testes off.
Right. So that can be done surgically by removal of the testis, or with medication shots that can suppress the production of testosterone by the testicles. And this is almost uniformly successful initially, but invariably, patients' tumors will start to progress. They become resistant to this form of therapy, and Jason just said they calls it castration-resistant.
I want to stop you. Is that why, because of that history, is that what directed all the attention to the androgen receptor? So cells have in the male body, they have a receptor for the androgens, for the testosterone, and a lot of research was directed there.
Yeah, so the actual genesis of this were some fairly unusual observations. For example, that eunuchs do not develop prostates or prostate cancer. And it was observed that the prostate itself was a hormone-responsive organ. And there were some urologists at the University of Chicago, a guy named Charles Huggins, who did the seminal work in this area, demonstrating that if you interfere with the androgen or testosterone system, you can elicit responses, clinical responses in patients with metastatic prostate cancer. And this urologist, Charles Huggins, went on to win the Nobel Prize 25 years later in 1966. And our understanding of prostate cancer has evolved quite considerably. We now understand that male hormones interact with their receptor, the male hormone receptor or androgen receptor, and we have an understanding of how tumors evolve resistance to this therapy. This is called castration resistance, a term that might not be that palatable, but is actually quite accurate.
Okay, I don't know when to get into this, but finasteride and the 5-alpha reductase inhibitors, they decrease the severity or the grade of
That's a whole other topic.
Right, I know it. I knew you were going to say that. But,
let's
why not everybody take
that?
Every male in the country.
That is a philosophical question, an interesting way. But I will get back to it. I'll write it down. We'll get back to it. Let's stay with the androgen receptor, manipulation.
So the tumors are almost uniformly sensitive and respond to therapies that alter the production of male hormones, some form of castration, be it surgical or medical castration. When the tumor starts to progress, such as in Jason's case, what we know in almost all cases is that this hormonal environment is reactivated. The androgen receptor is reactivated. And the tumor has evolved mechanisms that allow this hormone receptor, this androgen receptor, which drives the growth of the cancer, to become reactivated despite not getting its primary source of fuel, testosterone from the testis. So there are all kinds of mechanisms that allow this growth factor, this protein called the androgen receptor, to reactivate.
So they're mostly downstream mechanisms, right? They're intracytoplasmic
Right.
protein messengers.
There are many mechanisms, and some of them, for example, are still dependent upon male hormones. Like one example is that the tumor can utilize male hormones produced by the adrenal glands, which normally sit on top of the kidneys. They produce low levels of male hormones. And a really clever adaptation that the tumor cell uses, it can recreate the entire enzymatic pathway that the testis uses to make testosterone. And testosterone, interestingly, is produced from the starting point, this is what we call the starting substrate of cholesterol. And it's converted in a multiple step fashion from cholesterol to testosterone, and the tumor cell, the prostate cancer cell, which normally doesn't do this, actually learns to make testosterone from cholesterol. So with an understanding of the underlying mechanisms that allow the male hormone receptor to be activated despite the patient having very, very low serum testosterone levels, by understanding those mechanisms, we have developed therapies that can interfere with those adaptive mechanisms and result in responses and improved outcomes.
This is abiraterone and enzalutamide.
Correct.
Yeah. And did you, Jason, have one of those two?
I'm sorry, can you repeat them again?
Abiraterone or enzalutamide, are those familiar medicines? Did you have one of those two medicines?
I don't believe I did. I had the several different varieties of ADT, and then I most recently was taking Zytiga.
Yeah, Zytiga is abiraterone.
That's abiraterone. That's abiraterone.
Go ahead.
Yeah, that's abiraterone. Yeah. So ADT.
So
Right.
Go ahead. We'll talk
Yeah,
about
so
that.
I had that, but it, again, when I got my new scans in and it showed a lot of progression, we decided that wasn't working and changed course.
Gotcha. ADT.
So ADT, it stands for androgen deprivation therapy. Largely what we're talking about, at least initially, is what we just talked about.
Lupron.
Lupron, a way of medically or surgically castrating a male. Now we have these other therapies that target the hormonal milieu in different ways. So one of the drugs that we have is something called abiraterone acetate, or Zytiga. It's easier to say. It's the brand name, which interferes with the production of male hormones as it occurs in the adrenal gland or in the tumor cell itself. These two other sources of male hormones that the tumor cell can rely on to stimulate the growth or activation of the androgen receptor and consequently the growth of the tumor cell. There's another drug you mentioned, Drew, called enzalutamide. It's also known as Xtandi. It actually works slightly differently. It interferes with the ability of male hormones to interact with the male hormone receptor. So it's preventing the key from turning on the ignition, if you will.
And there's some downstream stuff coming, right? What's the thymidine system or something? Or I can't remember what the hell they were looking at.
So there are a lot of drugs that are in development that to target the male hormone receptor directly or to interfere with its stability or production. These are all in what we call a preclinical phase. They're in drug development. There's one or two that are in early phase, what we call phase 1 studies, which are essentially testing whether or not they can be given safely to a patient.
I think it was the production ones I was seeing research on. Looked pretty exciting.
Yeah.
Yeah. And so let's cut right to Jason's thing. We've got more. Sorry, everybody. I told you we get in the weeds. You have to follow very carefully. The targeted radiation therapy.
So radium. So if you remember going back to high school chemistry, you had the periodic table, and there were columns, and the elements in a given column have similar characteristic properties. And radium is in the same column of the periodic table as calcium. We all know that calcium is a bone-targeting, a bone-homing element. So radium also homes to bone. And what this particular therapy that Jason is on, what it is a radioactive form, an isotope of radium that emits a very powerful, what's called alpha particle. It's basically energy that can kill the tumor cell. And one of the benefits of this is that it is very selective for the bone. So it goes to the bone where prostate cancer likes to metastasize, and it will kill the tumor cell. It has what's called a very short linear range, which means that it won't go very far. It will really only kill the cells that are immediately adjacent to the radium. So even the bone marrow cells that may live nearby to the bone metastases, the prostate cancer metastases, are modestly or minimally affected by this therapy. So tends to be safe and fairly effective.
I've seen research that has not yet been released, Jason. It caught my attention. It's impressive. So I personally, I would,
Excellent.
Let's see what Dr. Rettig says.
Yeah, so this therapy is given 6 times, once every 4 weeks, and then it's stopped. Ultimately, I think, Jason, you'll probably not start to need to plan on therapies down the line.
Yeah.
Okay, because although the radium is a very good therapy, it won't make this cancer go away. It will
Right.
not eradicate it.
Right.
So more therapies are going to be needed.
Now, Jason, I'm going to put you back on hold because we're going to get into the weeds on some stuff that I think may be useful to you too, okay? I'll put you on hold. Thank you for the call, and good luck with this, man.
Okay, great. Thank you.
All right, you bet.
So just one other question. For somebody like Jason, which he's not here, you're at UCLA, what is the access to experimental trials? Is there a central place people should, or is it if you're out in the sticks somewhere, you're not going to have access? Is there?
It's a great question. So first of all, there's a great website called clinicaltrials.gov. Every single clinical study in the United States has to be registered there, and there's a very simple search mechanism. And you can search under prostate cancer and metastasis or metastatic prostate cancer, and you can find a list of clinical trials as well as the locations for those clinical trials. Of course, clinical trials are largely performed at larger hospitals or academic centers. So for someone who's not does not live in proximity to those places, they may have to travel.
But you would find out what's out
exactly,
there.
exactly.
So let's use Jason as a prototype. And this is Jason. We're not treating you. We're not talking about treating you. We're just sort of using it as a model for thinking about how the way this cancer research is going could potentially benefit cases like you, which would be, you talked about down the line. Now, would some of down the line therapy include genetically figuring out what's going on with that particular tumor?
Yeah.
Okay, let's talk about that.
So more and more, we have the capacity to get down to the weeds of the genetic environment of each individual's tumor. So with the power of modern day what we call next generation sequencing, we can sequence patients' tumors and critical genes within the patient's tumor and gain insight into those genetic changes, those mutations that may be driving the growth of the cancer. And remember, the DNA or the genetic code is really serving as the map, the code to make proteins, and it's really the proteins that are driving the growth of the cancer.
Let's even back up further. I mean, cancer is an error in the genetics of a cell that creates it to grow an abnormal cell, not the usually differentiated cell, in an uncontrolled fashion. Now, we're going to talk about it. Your immune system can pick up on that and get it, or can miss it for various reasons, which we'll get into.
So when you have abnormal genes, you have abnormal proteins, and some of these proteins have uncontrolled activity. They're turned on, and the normal mechanisms to put proteins, growth-driving proteins, on the brakes are lost. Okay, so we have drugs that can potentially inhibit the signals that are driven by these abnormal proteins. And as a consequence, I think it's important, and it's becoming more and more routine for the patient's tumor and even what we call their germline DNA, and we can talk about that, but especially their tumor, to undergo genetic sequencing. And this can be done from any hospital. There are commercial entities that will do this for a relatively modest fee. You get a genetic report back, the list of mutations that are abnormal in the patient are presented, as well as potential drugs and clinical trials that may be beneficial to that individual.
Give us an
patient.
example of a targeted drug therapy for a genetic abnormality.
Great example.
Something that excites you.
Yeah, so let's say, for example, let's take skin cancer, melanoma. Okay, there's a mutation in half of those patients. It's called BRAF is the name of the gene. And if it's mutated, there's about a 75-80% response rate to a drug, an oral agent, that will inhibit that particular abnormal protein. If a patient with prostate cancer has that same abnormality, in theory, that same drug could be applied. So one can take drugs that have been approved for other indications and apply it to prostate cancer. And that's one of the exciting things about doing work in prostate cancer, is that we're discovering genetic changes in prostate cancer, and those treatments that arise therefrom can be applied to other cancers.
We're going to talk about that in just a second. Okay. Wait, do we need to take a break, Susan?
Oh, of course.
Okay, and Bruce, you want to ask you a question after the break?
Sure, after just the difference between genetic testing, people see 23andMe and stuff like that, and what you're talking about, the genetic finding out
versus. Go ahead and answer that.
Sure. So it's very, very different. So the genetic testing that tries to determine your ancestry doesn't necessarily look at the genes themselves. So the human genome is made up of 33 billion different what we call nucleotides. And only a small percentage of those, 1 or 2%, are actually involved in the production of proteins that regulate the growth of cells. So these websites, these services that can determine your ancestry are largely looking at DNA that is not involved in the production of regulatory proteins. They're really parts of the DNA, sometimes called junk DNA, that can be used to track back in time your ancestral history.
Where that junk came from.
Yeah.
Right.
Yeah.
But you can't tell if someone's at increased risk if you have a BRCA gene.
Right.
That's different.
It's different. It's totally different than what you're talking.
Totally different.
Right.
But you can get that testing now. I used color.com. I just think they're great.
So color, it's a great, very simple test. That's for hereditary cancer. You basically spit into a cup and you get 30 genes back. But there are gene panels on the tumor cell itself.
Which is different.
Right.
Which is thousands of tumors, thousands of proteins.
That's right. So they're talking about up to a couple thousand or more different genes that are known to be mutated in human cancers and that could be driving the growth of the cancer. And all of those are precisely sequenced from the patient's individual tumor, and the report comes back, and that can inform therapy.
And oncologists today, like Dr. Ray, are used to seeing those reports. I see those reports now, and my head swims immediately.
Yep. Well, me too.
I look at those now and go, oh, how am I supposed to understand what they're talking about? Because I have no frame of reference, and it's such fluid. You guys use that information so fluidly today that even in presentations at conferences and stuff, I'm like,
Yeah, it's like learning another language.
Yeah, it's another
That's
language.
once you have cancer.
Right.
Yes,
And then there are also some tests that can tell you if you might be at slightly increased or increased risk.
That's
Absolutely.
the color.com.
Right.
That's okay. We'll take a little break.
Did we say goodbye to Jason?
We did say goodbye to Jason. I put him back on hold, and I told him to listen. And,
Okay.
And we were done with
Should
Jason.
we keep him there, or should we let him
No,
go?
Jason can go unless maybe Lindsay wants to talk to him, and if he has any further questions, because we just wish Jason the best. And it's not the worst time to have what Jason has. I got to tell you, a lot of hope, a lot of stuff being done. And the way, this is why I'm excited to be part of Prostate Cancer Foundation, because literally there's stuff that could benefit somebody like Jason
Absolutely.
next week.
Right.
It's evolving that fast.
Yes.
It's evolving that quickly.
Absolutely.
Let's take a little break. I want to thank our sponsor, Hydrolite. These guys, I rave about them all the time. Go to the banner at drdrew.com for details. You get a 30% discount for everyone who clicks on that banner and uses the code DRDREWHY, Dr. Drew HY, Hydrolite. And that's
why I got sick. I didn't take my Hydrolite to Europe with me when I
why
charged.
you aren't taking it?
That's
I'm
the
sorry,
problem.
Susan's not beating you over the head with it right now. This
didn't
is
give
her
me-
favorite product. All right, we'll take a little break and be right back. All right, it is fall and your immune system is about to get tested, everybody. Not only does the changing weather mark the start of cold and flu season, it's also back to school time when kids become walking petri dishes. While catching something may be inevitable, there is no excuse for letting yourself get dehydrated in the process. So when you're wiped out with cold or flu, the first piece of advice, always to drink plenty of fluids, but we seem to forget that. Now, once you've started feeling dehydrated, it's already too late for water or sports drinks. Rapid rehydration requires the proper balance of sodium, glucose, and water, and nothing gives this like Hydrolite. Hydrolite's formulation is based on established, proven science, and it is the simply best rehydration product I've found in this country. Hydrolite comes in great flavors, orange berry lemonade, and it's available in a pre-mixed drink, a powder, or what I prefer, those effervescence tablets. You just drop them in a glass of water or a bottle of water, off you go. It's like your own portable IV, but you can do it enterally. Compared to sports drinks, Hydrolite delivers up to 4 times the electrolytes with 75% less sugar. Hydrolite solutions are appropriate for all ages, and each bottle or package includes easy-to-use, easy-to-follow instructions. You can find Hydrolite at Rite Aid or online at Amazon.com. And for a limited time, our listeners can save 30% on Hydrolate. Just click the banner on our site, drdrew.com, and use the code DRDREWHY, DRDREWHY at checkout. That is DRDREWHY. We are back. I want to thank also not just our friends at Hydrolate, but also our friends at Alliant.edu, the great services they offer there, the Alliant Psychology Training Group. Again, place I've worked alongside of those students for a long time, and they're quite good. Lindsay talked to Jason. Lindsay, our crack call screener. You got some information.
I'm here. I've got information. Jason said that he tried out that government study you mentioned.
No, you went to the website.
The website, clinicaltrials.gov.
Yes, he visited your website, and he said he did go through with their trials. He said it wasn't helpful in his situation.
We know that. Yeah, you told us that.
He did say that he had free room and board. He had some free meals, so they did go above and beyond to help him out financially as well.
So it's not just covering the research, it's getting you there and covering your stay and stuff like that.
Very often it is, yeah.
Good. Thanks, Lindsay. Appreciate that.
Thanks.
Let's quickly, before we go down to the weeds again about our genetics, let's deal your question, Bruce, about Proscar. Actually, somebody has that question. Let's see if he's on there. Let's let him talk to us about it. This is, I don't know why this, Nate, I'm having trouble with the computer. It drops down as opposed to doing what I want it to do. Lindsay, can you put...
Well, we have the guy on Zoom. You can talk to him.
No, this is a specific question we want to get
Finasteride.
into. All right, Steve, listen carefully. I'm going to ask your question for you, and you listen. No, don't worry, Lindsay. It's all right. I got it. So Bruce ask his question about the finasteride. You had the question about the...
Yeah, take the 5-alpha reductase inhibitors, finasteride. They decrease, from what I've seen in the studies, they decrease the severity or the grade of tumor if you get prostate cancer.
Not quite.
Okay. So you tell me.
That's
but
the
these
problem.
are things, they're being prescribed just all over the place, it seems like, and they're at different expectations
You should. When I was diagnosed, they actually brought that up to me, and they went, well, you could do it. It sometimes works, but it sometimes increases the aggressiveness of the tumor. Right? And I thought, well, I can do without that, thank you. But your question really was, why wasn't everyone on it to begin with to prevent cancer, right? Which is a different
possibility
question.
Of decreasing the incidence, but increasing the aggressiveness is the issue.
Right.
Okay.
So let me explain what we're talking about here. So there's a class of drugs that you mentioned called 5-alpha reductase. One of the first ones was Proscar, also known as finasteride. And what it does is it prevents the conversion of testosterone to a slightly more active form of testosterone called DHT, or dihydrotestosterone.
People use it for male pattern balding.
It can be used for male pattern baldness, and it's also used for
prostatosis.
BPH. BPH, or an enlarged prostate that's not cancerous.
Right.
Okay. It was also...
And it works in both those cases.
That's correct.
Yeah.
Absolutely. The question was asked, well, what happens if we give it to patients without prostate cancer? Can we reduce the incidence in the development of prostate cancer? And there were a couple of controlled trials that were done, and there is actually about a 25% reduction in the incidence of prostate cancer. But in these studies, one of the problems was that in the patients who were diagnosed with prostate cancer in the arm that received the Proscar or the finasteride, they had a higher frequency of more aggressive, what we call high-grade prostate cancer.
Which fits with my understanding of the physiology of prostate cancer.
Yeah.
It's a wily beast.
Yeah.
You know what I mean? You push on it one way, it goes the other way.
Right.
Would you agree?
That's exactly right.
Yeah.
That's any cancer. If you push on it one
especially
way,
prostate.
it will adapt to that push and move in a different
So
direction.
you may be causing some of those testosterone-producing pathways that you were talking about in patients.
That's right.
And so that particular reason was why the FDA did not approve the drug, even though it reduced the risk of prostate cancer overall. These were the non-aggressive forms of prostate cancer. And what it seemed, at least in these trials, was that the more aggressive cancers became slightly more predominant. And as a consequence, the FDA said no to that class of drugs for prevention of prostate cancer.
Let's go now to where we were discussing how research in other areas of cancer helped prostate. Let's talk about prostate helping other areas, such as we have Jimmy Carter now alive, really because of the kinds of research we're doing on prostate.
Right. So I think, Drew, you're talking about immunotherapy.
Right,
and
which is to me, and I'm sorry I keep interrupting you, but this is all exciting stuff for me. The radium therapy and the immunotherapy are the things when I listen to the research papers and I sit as an audience member, I think, oh my God, there it is. Those are and you see the researchers get excited too.
Yeah.
So, go ahead.
So immunotherapy has gotten a real big boost over the last several years. Historically, our ability to manipulate the immune system to attack a tumor cell has been really limited. And in the major cancers that human beings get, prostate cancer, breast cancer, lung cancer, colon cancer, we haven't done a very good job. However, more recently, there's been a class of immunotherapies that overcome a mechanism that the tumor cell uses to inhibit or suppress the immune system. And these are the therapies that everyone is hearing about in the news, in the papers, in the press.
Let's restate it again. Exactly what the tumors develop ways to get around our immune system.
Yeah. So the immune system essentially needs to do two things to get rid of a tumor. It needs to be able to recognize the tumor as something that shouldn't be there. It's foreign. That's why our immune system recognizes a bacteria, an infection, so well, because it's so different from its host, the patient.
Right. And these tumors learn how to get away from the immune system, how to hide out.
That's right. So the first process is recognition. The second process is killing the tumor cell. And in particular, that's where the tumor cell has evolved mechanisms to prevent an immune cell, which may recognize it, but prevent it from killing it. And that's where all of our current therapies that we hear about, these immunotherapies, have been effective. They're particularly effective in cancers that have a lot of genetic changes, a lot of mutations. And that's because when a tumor has a mutation, that results in a different protein. And that mutated or different protein is seen by the immune cell as different from the normal cells.
More easily recognized.
Right. So the first step in this attack system, the recognition step, is more efficient for tumors that have more mutations.
Right.
And for example, we mentioned Jimmy Carter. He has melanoma. Of all the cancers that human beings develop, melanoma has one of the highest mutational burdens.
Right.
So the tumor cells can recognize it.
Right.
So the therapy that targets the second step, which is the step that the tumor cell uses to inhibit the immune cell, that therapy is particularly effective in melanoma and other cancers that have lots of mutations. A good example is lung cancers. A lot of our, quote, targeted therapies work on lung cancers that don't have a lot of mutations and are actually effective in non-smokers. So lung cancer actually can develop rarely, not too rarely, in non-smokers. But it's in the smokers who are exposed to a carcinogen, tobacco smoke, that mutates the DNA. Those are the tumors that respond most well to our newest immunotherapies because the first step, the immune system recognition of the tumor cell, is intact.
Right. Now, I had a buddy from medical school just had neuroendocrine cancer and came back 0 mutations. Is that possible?
It's possible that zero, what we call driver actionable or driver mutations were detected. The tumor does have mutations, but
has to.
Yeah.
Right. But 0 actionable was not a good end.
Right. Exactly. Yeah.
And tell us briefly, if you can, how one of these paradigms works.
Yeah. So, and then we'll talk about specifically immunotherapy for prostate cancer. But essentially, once the immune cell recognizes the tumor, it's in the local environment of the tumor cell. And the tumor cell will be adjacent to the immune cell. And on the surface of the tumor cell is a protein that interacts with a protein on the surface of the immune cell. And this protein-protein interaction actually suppresses the immune cell. There's a signal that's sent inside of the immune cell to turn it off. And this interaction is called PD-1 and PD-L1 or PD-L2. It's an interaction between the protein on the surface of the immune cell called PD-1 and a protein on the surface of the tumor cell called PD-L1. There are other proteins that can function in this regard. And the therapies are what we call monoclonal antibodies that very selectively, specifically recognize one of these proteins, either PD-1 or PD-L1, and block the interaction, the physical interaction between these two proteins, and allow the tumor cell the immune cell to do its thing, to kill the tumor cell. So it is inhibiting the inhibitory process. That's what the therapy does.
It's very exciting research.
Yeah.
And you'll see when you go to cancer research, a lot of PD-1. PD-1 is up there all the time. There's
Right.
PD-1 research.
Exactly.
So, Bruce, you also have a Zoom guest you want to introduce to us.
Dave Perez, good buddy, and he's a cancer survivor, prostate cancer survivor. And he's very active. He just went to some prostate meetings last week, and I let him ask a couple of questions. Dave,
there you are. Hey, man.
Yes. Good afternoon, gentlemen. Curious about a couple of things. In particular, the genomic testing that can be done now. As I understand it, there's now the ability to test negative cells, negative pathology. So if somebody goes in for a biopsy because there's a suspicion of prostate cancer, but then all the pathology comes back negative. Now there is testing that can be done to confirm whether or not prostate cancer might exist.
So close. So one of the problems is when a patient is suspected of having prostate cancer, for example, because their blood test, the PSA, is elevated, a biopsy is done, and the biopsy, in theory, may miss the site where the tumor is. So the pathologist says no cancer, but it doesn't mean that there's no cancer in the actual prostate.
You may have just missed it.
Yeah, right.
It's an ice pick. It's a needle, so you might miss it with the ice pick.
Exactly. We're not removing the prostate to try to detect the cancer. These are often random biopsies. And what we can do is a urine test. There's a urine test called PCA3, which will give the doctor a likelihood that the patient has prostate cancer despite a negative biopsy. And that can be used to make a decision about if and when a patient, or how frequently a patient should be re-biopsied to try to establish the diagnosis.
This brings up the issue of active surveillance generally. Go ahead and talk to us about that. I was in active surveillance for a while.
Yeah. So at the outset of our discussion today, we talked about the fact that most patients with prostate cancer have an unaggressive, indolent form of the disease that's not going to threaten the patients.
This is why the U.S. task force was so adamant about their position. They thought we were over-diagnosing,
Right.
And that we were treating people unnecessarily.
Right.
Yeah.
And that may be true. So the key is if you have a patient who, based on the standard pathological and clinical factors, has an unaggressive cancer, the patient doesn't necessarily need surgery or radiation, which has a lot of long-term complications that can affect quality of life.
And different decades of life, too.
Exactly.
How you'd approach it, what you do with it, what it means.
Exactly. So in patients who are diagnosed with an unaggressive form of the prostate cancer, patients can undergo something called active surveillance, where they're closely monitored, their PSA is checked on a regular basis, they do a digital exam, and a biopsy is repeated over time to determine whether or not the cancer has evolved from an unaggressive one to a more aggressive one that may require therapy. Okay?
I have a couple of questions along that line, if I can.
Before you do, when I was in surveillance, the data that I was sort of presented with was a third of the time it stays the same, third of the time it gets worse, third of the time it gets better.
Right.
It gets better by itself.
Right. And so when you put a needle in and you put it in blindly, it's just that, it's blind. And sometimes there are multiple prostate cancers in the same patient. So if you take out a prostate of a patient who is diagnosed with prostate cancer, there are at least typically 3 or 4 genetically independent prostate cancers. So the biopsy may have detected one that's unaggressive, and a second biopsy a year later may actually detect one that's aggressive. So one of the tools in our armamentarium that has been developed over the last several years are targeted biopsies. And what can be done is a very, very high-resolution MRI of the prostate. And the MRI of the prostate can't be done in the biopsy suite. It's a separate process that's done in the radiology department. So in this process, what can happen is the images from the MRI are uploaded into an ultrasound machine, which is used in the biopsy suite. And the ultrasound images are overlaid with the MRI images, and you can see on the MRI where the key abnormality is, and then you can target or direct the biopsy to that area. So a lot of patients who have an elevated PSA, for example, who have a biopsy that doesn't reveal prostate cancer, when they get the targeted biopsy, the cancer is revealed.
So go ahead. I'm sorry to interrupt you. Go ahead.
No, that's okay. So what about the role of that imaging to supplant the use of the biopsy? In other words, at what point can you forego biopsies and rely just on that imaging? And then a follow-up to that is, where do you draw the line, because it seems to be an evolving landscape, between the transition from active surveillance to active treatment? What are the trigger points?
I want to know. I have some follow up on that too. So go ahead.
Okay, so
those are great questions. By
those
Dave.
are great
Yeah,
questions,
yeah.
and if you want to work in my lab, it sounds like you would do a good job. So first of all, we'll get to the MRI question. It's interesting. There are different factors or parameters on the MRI which can actually predict whether or not the cancer is aggressive. The problem is it's imperfect, okay? So the MRI may miss aggressive cancers, and in theory could occasionally call an aggressive cancer that's not aggressive. So although...
At this point.
So although...
I, by the way, haven't seen any research. Maybe we don't see the radiology research very much, but I haven't seen a lot of active research trying to make that better. Is it going on?
There's a lot going on in that area.
I just haven't seen it. Okay, go ahead.
So the MRI is particularly useful in the fact that it could identify the abnormality in the prostate that is most likely the most aggressive one, but it's imperfect. So it's possible that a patient has an MRI and it show low-grade disease, but you can't forego the biopsy because it's possible that when you put the needle in, it shows more aggressive disease. That would require treatment.
And will there be a day when we can forego the biopsy and just use the MRI?
I think so. I hope
One
so.
day.
Yeah.
So one day.
And that could be a combination of not only imaging but urine and blood tests.
Yeah.
That.
Then now he's asked an even more nuanced question, which is, how do you go from active surveillance to treatment? And let me tell you my own personal story. So I was getting done. Everyone was always a little uncomfortable with my tumor because it was central, and there was a fair bit of volume. What did that mean? What would that mean to you?
So central means in the middle of the prostate. Yeah. So the prostate has different zones, and most commonly the cancers arise in what's called the peripheral zone, which is the outer part of the prostate that you can actually feel when Dr. Bruce does a digital exam in the ER.
Yep.
So that's the advantage for the clinician, is that most, say 70-75% of prostates occur in a site where you can feel it on exam, and you can get to it more easily with a biopsy. When the cancer is located more centrally or even in the front of the prostate, which is called anteriorly, it's more difficult to get at with a needle. It's more difficult to image. So following a patient such as Dr. Drew, who had a tumor that may have been more centrally located, may not be optimal.
For following.
But for active surveillance.
Well, they did the active surveillance, and they got tumor every biopsy, and it was always the same grade, low grade, blah, 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 never changed. Still talk about whether they were getting it all, and those kinds of questions were in everyone's head. But the volume suddenly expanded.
Right.
And there was never any change in the grade.
Right.
Do we assume there was a change in the? And by the way, when they took my prostate out, I think they found 1 3+4 or something,
Right.
but everything else was 3+3. Everything.
Yeah, that speaks to the limitations of what we call an aggressive or unaggressive cancer. Ultimately, what's aggressive is something that's going to threaten the patient's life, that's going to spread.
It's growing.
Right, it's growing.
Yeah, mine was growing.
Exactly.
Yeah.
So what you've been talking about is this 3+3 or 6. It's called the Gleason score, and it's a grading system that the pathologist uses to determine how similar or dissimilar a cancer looks compared to the normal tissue. And the higher the score, the more aggressive. So the pathologist will score 2 sites. There's a predominant site, which is the first number scored in 1 to 5, so a 3 in your case, and the secondary site, the smaller area, which is called the secondary score, also gets a score of 1 to 5. And yours is a 3. So 3 plus 3 is considered unaggressive. 5 plus 5 would be the most aggressive. And any 8 or higher is very aggressive, very aggressive. But even when you start to get 7, especially when the first number is a 4 and the second number is a 3, we're talking about a potentially very aggressive tumor.
Do they drop?
They can drop, but that tends to be a sampling error, right? So on a biopsy, what we know is that 25 to 30% of the time when you actually take out the prostate, the score is higher. There's also a similar but a phenomenon that we see where a high number becomes a low number on in the prostate cancer, the prostate specimen, the whole prostate, but that's less frequent. So there's a concern that when you have a Gleason score in a biopsy, it's not representative of really what's going on in the prostate as a whole. In addition, the Gleason score itself, even if the biopsy is accurate and reflects what's going on in the prostate as a whole, is an imperfect measure of how aggressive the cancer is. And you
I was going to say, mine when they took the prostate out, they found some projections were making for the capsule. Wow. They were on their way. They were heading for the outside world.
So we
and
know
a 3 plus 3 was doing that.
So So we know that some low grade, low Gleason score tumors, a 3 plus 3, can behave aggressively, as it did in Drew's case, and can metastasize. And sometimes we even have genetic information where if a patient has a metastatic tumor and you get a piece of tissue from the metastasis, the site that's spread, and you also have the prostate, and I said there can be multiple different cancers in the prostate, sometimes the genetic origin of the metastasis is not the highest Gleason score tumor, but may even be the lowest Gleason score tumor.
Is there a move to get rid of the Gleason system? I don't know if Dave was mentioning that. Or
there are moves to modify it. That has happened, but it's still an important part of the initial evaluation of a prostate cancer.
I still would love to see the genetics on my cancer. Really interesting, because it's a weird, something's weird about it. And you know I'm an MSH6.
Right.
Does it have something to do with that?
It could.
Yeah.
So
why can't you get the genetics of yours?
Because it's gone. I don't know. Maybe somewhere.
No, you can't.
You can't.
All right,
So
maybe
let's be clear about that. Once your prostate is taken out, or you've had a biopsy, it's typically stored in a wax block for 10 years. Some places more.
I just figured it's a couple of years, and that was it.
And you remember, we can get the DNA of a dinosaur, so that DNA is very stable.
So we can get Drew's.
We can get Drew's DNA.
Let's do it.
So it's sitting at UCLA.
Yeah.
Have at it.
And it can be tested.
Well, actually, it was at Cedars, but it's Skip Holden's thing, so he's got.
We won't mention that place.
But I will. But still a UCLA facility, to be fair. But to drill in on Dave's question, which I think is still the case, is that there's a big piece of physician judgment in all of this. Yeah. That a call by a well-trained urologist with lots of experience is still a necessary ingredient in this whole process. Isn't it?
I mean, we have a lot of technology to support us, but ultimately, you still need.
I mean, when Skip called me and said it's time, I'm like, let's go. I was ready then, because I've been on surveillance for a while, and I figured time was coming, and I was ready. But if I had made an issue of it, and I don't want to go, maybe we wouldn't have done it. Maybe we would have done something else, or who knows.
Right.
But the point is, it's a physician and a patient making that determination.
Right. There's no replacing clinical judgment.
Yeah. Which is, Dave, thank you for that, because I think there was a good place to put that in. How does someone know if they are? I don't want to put this in a pejorative context, but they've gotten sort of the full benefit of what's available out there. Is it doing your own research, or should the average urologist be able to tell you, if you want to do more, here's where you go. Go to one of the clinical researches or whatever.
That's a great question. I think that in general there are a lot of excellent physicians who treat prostate cancer, both from the surgical standpoint, a urologist, or the radiation standpoint. But like with any profession, there are good doctors and bad doctors. There are good lawyers and bad lawyers, and I think you have to know your doctor and do your own research.
Do your own research. I think that's kind of what I was looking for. I think an educated patient but there's a lot of confusing stuff out there about nonsense too.
Yeah.
How do you, as always, a Google search is a dangerous instrument. Yeah. How do we sort through it?
And I would say one thing: if you are asking your physician a question and you don't get an answer that's that you understand, I think that's a red flag. You need to be able to get the information from your physician so that you can participate in the decision as to how to manage your particular prostate cancer.
Other questions? Anybody? Susan, did you have questions? Did you understand? Did it make sense? It made sense,
well,
yeah.
I've been there. I also didn't like your first doctor, and we went to another one after that because he didn't answer my questions well enough.
Yeah. And she was feeding me tomatoes at that point. That was supposed to cure my cancer.
Well, no, but that brings up
green tea and soy milk.
Right. So that brings up what I was looking at: green tea, soy, cruciferous veggies, tomatoes, especially cooked in olive oil, increase omega-3 fatty acids.
That was all the stuff.
Decrease calcium.
She was gaming. She was gaming
hurt.
on that.
Well, they gave me a book. That
I
said
understood. You were. Listen, I went with it. It's all right.
no dairy.
Metformin. We could talk about metformin.
Right.
I know Dave's had a little different treatment process in addition to traditional. I don't know, but metformin. He's still on metformin.
Yeah.
That is true, and it does seem to. It's interesting to me because there's a lot of anecdotal evidence, and I would like to touch on the dynamic about the patient-doctor relationship a little bit because I talked to 4 doctors after my diagnosis that all recommended treatment before I found my way to a major teaching hospital that's known for its work with prostate cancer before I found a doctor who said, no, I could go on active surveillance. And that was 9 years ago. So, and, I continue through it today. So there is, a fair amount of, networking, talking to other people. The idea, I would like to hear more Dr. Rettig's views on metformin and the influence of the, insulin reaction on prostate cancer and how that's all coming together. Because it seems like there's more and more evidence out there about metformin having impact with multiple cancers. It wasn't that long ago that it seemed like, well, all this hype about metformin is going to be overblown. It's going to go away, but it hasn't. It's continued to be a topic of interest. I'd love to hear you guys' comments on that.
Sure. So prostate cancers, like normal prostate tissue and other tissue and normal tissues in general, have a metabolism. They may have an altered metabolism, so they're reliant on different sources of fuel, if you will, than the normal cell. So an increasing understanding of this has led to hypotheses that relate to certain hormones like insulin and insulin-like growth factor, and how we might be able to modulate these to prevent or even potentially treat a cancer, including prostate cancer. And there are what we call correlative studies, epidemiologic studies, which seem to show that drugs like metformin, which is classically a diabetes drug that can interfere with insulin metabolism, can affect the incidence of prostate cancer. But these are not what we call prospective controlled trials, so they're not definitive. Clinical trials in this regard are ongoing to try to establish more unequivocally the role of metformin on preventing cancers and various cancers. So what I would say about metabolism and diet is that we don't have high-level evidence that altering your diet will influence the cancer. However, there is certainly biologically plausible mechanisms that would lead us to understand that certain diets may adversely affect your cancer. So, for example, we just talked about insulin and insulin-like growth factor. These are hormones that are produced in different organs like the pancreas and liver that can circulate and latch onto the tumor cell, specifically receptors on the tumor cell called insulin receptors and insulin-like growth factor receptors. And when they latch on, they trigger a signal inside the tumor cell that tells it to grow. So if you eat a very high sugar meal, a very simple sugar meal, let's say you have 5 Snickers bars, well, your body is going to react to that by producing a lot of insulin to maintain your blood sugar, your blood glucose, within a certain normal range. all of that insulin is still going to be circulating around and could potentially stimulate a cell that has the insulin receptor on its surface. So that's perhaps an oversimplification of the process, but it is certainly biologically plausible. And anyhow, if you're going to eat a diet, why not eat a healthful diet that's good for your heart and may also be good for your cancer?
We are going to leave it there, Dr. Rettig. Thank you so much. This has been enlightening. Yeah. It makes sense now, right, Bruce? That's the we went through the landscape. Yeah. This is it. It actually helped me. I don't get a chance to think about the entire landscape very often from beginning to end. And it helps frame the research we hear and some of the controversies we read about. I hope it helped you guys understand it. Any last things you'd like to say?
No, I just thank everyone for this opportunity to get the word out about prostate cancer and get checked.
Go watch that video right now. Save the Males, savethemales.org. Go check out Many vs. Cancer, the Prostate Cancer Foundation. Be a part of the solution. And pennies help a lot. Also find us, of course, on Facebook, Twitter, at Dr. Drew, at Weekly Infusion. Go to drdrew.com. Check out the other podcasts. I've got one with Adam, one with Bob Forrest, a new one coming with Ami Horowitz. Oh, yes.
Howard Vortex.
Also, check out the award-winning now Dr. Drew podcast. Subscribe on the Podcast One website. And I hope this was helpful. This is really a good discussion of this. I would happily submit this to a medical school or even a residency if they wanted just a basic primer, not even a basic primer, a good primer on this topic. So thank you so much.
Thank you.
And we'll see you all next time.
Remember, you can find all these podcasts at drdrew.com. The Dr. Drew podcast, the This Life podcast with Dr. Drew and Bob Forrest, and the Adam and Drew podcast, which is available 5 days a week. Find them all on iTunes and rate us 5 stars. Subscribe and get it first. And if you're really happy, click on the Amazon banner at drdrew.com to help support the show. We'll thank you for it. If you join the email list via drdrew.com/contact, we'll send you a weekly infusion newsletter with Dr. Drew's news. We're so grateful when you get in touch. We read all your emails and we'll bring you the subject matter you want to hear about.